Welcome to the Deep Dive. We're here to take a deep look into complex topics, break down the source material, and give you the essential insights in a clear, conversational way.
And today, we're tackling something pretty huge. The whole landscape of mental health treatment. It's vast. We've got sources covering everything from, the classic talking cures going back ages right up to the latest biomedical stuff.
Yeah, it's a really complex world. So our goal today is clarity for you, the listener. It's not just about knowing therapy exists. We want you to understand who the helpers are. What are the big ideas like psychodynamic, cognitive, all those driving the treatments?
And crucially, how effective are these different methods? What does the evidence actually say? We'll break down the practitioners, dive into those four big psychological models, and then look at the biomedical side and how it all fits together, or sometimes doesn't.
Okay, sounds like a plan. Let's jump in. The most practical starting point, I think, has to be, who are the people doing the helping? Who are these professionals?
Right, because you hear all these titles and acronyms, PhD, PsyD, MD, LCSW, it can be confusing. But these distinctions matter because they tell you about the person's training and what they're actually licensed to do.
Okay, so let's start with these psychologists holding doctoral degrees. The clinical psychologist, what's their deal?
Clinical psychologists typically have a PhD or a PsyD, that's a Doctor of Philosophy or Doctor of Psychology. They're licensed. The training is really broad. Theory, research, and lots of clinical practice.
And what do they mostly do?
Their core work involves psychological testing, making formal diagnoses of mental disorders, and, of course, practicing psychotherapy. You could think of them as dealing with a wide range of psychological issues, sometimes quite severe ones.
Okay. And the sources mentioned counseling psychologists as well. Also doctoral level, also licensed. How are they different if they both do therapy?
Yeah, it's a good question. Historically, the main difference is often the severity of the problems they focus on. Counseling psychologists tend to work with issues that are, let's say, milder on the spectrum.
Milder how? Like everyday problems?
Sort of. Things like career counseling, educational choices, coping with life adjustments, helping people use their strengths to navigate, more typical life challenges rather than severe mental illness necessarily.
Got it. That distinction makes sense, especially when you think about needing medication for more severe conditions.
Yeah.
That brings us to the psychiatrist.
Exactly. Psychiatrists are the ones with the MD, the medical degree. They've gone through medical school and completed a residency specifically in psychiatry.
And that medical training is the key.
It's the fundamental difference. It means they understand the biological side, the brain chemistry, and critically, they can prescribe medication. Psychotropic drugs.
Whereas psychologists cannot prescribe meds, generally.
Right. In most places, no. So while many psychiatrists do still provide some psychotherapy, their role, especially nowadays, often leans heavily toward diagnosing and managing medication.
It was like a fork in the road. Need talk therapy and skills. Maybe a psychologist. Need medication management. Definitely a psychiatrist.
That's a good way to put it. But the field is even broader than that. We also have clinical or psychiatric social workers.
Right. They usually have a master's degree in MSW, and their focus seems different, more environmental.
That's a great way to describe it. Their training really emphasizes how the individual interacts with their social environment. They know the systems.
Systems like?
Community resources, government programs, support networks. They're often the ones connecting people to practical help housing, job training, financial aid. They help make treatment work in the real world by supporting the person's whole life situation.
That sounds essential. What about the term psychoanalyst? That brings up specific images, doesn't it?
It definitely does. Think Freud, the couch. A psychoanalyst isn't defined by their first degree, though they're usually already a psychiatrist or psychologist. It's about highly specialized additional training.
Training in what, exactly?
In the specific, very intensive techniques of psychoanalysis itself. We're talking years of extra study focused purely on exploring the unconscious mind. It's a deep, deep dive.
Okay. And then we have counselors and psychiatric nurses rounding things out.
Yep. Counselors are very common. They typically have a master's degree and work everywhere, schools, clinics, private practice. They handle a really broad range of issues, often related to adjustment, relationships, that sort of thing.
And psychiatric nurses.
Psychiatric nurses are registered nurses, RNs, who've gone on to get a master's specializing in psychiatric nursing. You often find them in hospitals, in patient units, residential settings. They're crucial for managing complex cases, administering meds under supervision, and providing that sort of bridge between medical and psychological care.
Wow, okay, so understanding who's really the first step for anyone trying to navigate this. It helps you figure out where to even start looking for help.
Absolutely. Matching the need to the right kind of specialist is key.
All right, we've mapped out the professionals. Now let's get into the substance of the treatment, the psychotherapy itself. The sources define it basically as talk therapy, based on psychological ideas happening over sessions. And they group most of it into 4 big models: psychodynamic, humanistic, behavioral, and cognitive. Where should we start?
Let's start at the beginning with psychodynamic therapy. This really grows out of Sigmund Freud's psychoanalysis. The core idea here is that our problems, anxiety, depression, repeating bad patterns, come from conflicts buried deep in our unconscious mind, usually starting way back in childhood.
So the goal isn't just symptom relief, it's digging deeper.
Exactly. It's about bringing those hidden conflicts out into the open, into conscious awareness, so you can understand them and work through them, stop them from controlling you from behind the scenes, so to speak.
Okay, but if it's unconscious, how do you even get at it? Seems tricky.
Freud developed some specific tools for that digging. The most famous is probably free association.
Just see whatever comes to mind.
Pretty much. The client lies down, gets comfortable, and is encouraged to say absolutely anything that pops into their head. No filtering, no censoring, no judging. The theory is if you let your thoughts flow freely, the usual defenses drop, and clues about the unconscious stuff start to leak out.
That sounds harder than it looks. We're always filtering, aren't we?
It's incredibly difficult, takes a lot of trust. Another key technique is dream analysis. Freud famously called dreams the royal road to the unconscious.
Because they're symbolic.
Right. Dreams have 2 layers, according to this model. There's the manifest content, that's the actual story you remember, the images, the events. But underneath that is the latent content, the hidden symbolic meaning. The therapist helps interpret that latent content to figure out the underlying unconscious wishes or conflicts it represents.
So the therapist is like a detective, gathering clues from free association, from dreams, and then using interpretation to piece it together for the client.
Precisely. Interpretation is where the therapist explains the links between what the client says or does and those hidden motives or conflicts. It's about providing insight. But the sources really emphasize one specific use of interpretation as being the most important.
Which is?
Analyzing the transference relationship. This is a cornerstone concept.
Okay, break down transference for us. It sounds complex.
It is, but think of it like this. Transference is when the client unconsciously starts projecting feelings and expectations from important past relationships, like with a parent or sibling, onto the therapist.
Oh, they might react to the therapist as if they were that parent.
Exactly. Maybe they had a really critical father, and now they feel constantly judged by the therapist, even if the therapist is being completely neutral. Or maybe they become overly dependent, trying to please the therapist like they tried to please a distant mother. Analyzing these projected feelings in the therapy room helps the client see how those old patterns are messing up their current relationships.
Wow, so the relationship with the therapist becomes the main tool for understanding. What about the flip side? Countertransference.
Countertransference is when the therapist does the projecting. They unconsciously start relating to the client based on their own past relationships or unresolved issues.
Like if a client reminds the therapist of their rebellious teenager.
Yeah, exactly. The therapist might become overly critical or maybe overly indulgent because of their own stuff, and the sources are crystal clear. Countertransference is bad news for therapy. It gets the therapist's needs tangled up in the client's treatment.
Now, classic psychoanalysis sounds incredibly long and intense. Sessions multiple times a week for years. Does anyone still do that?
It's much rarer now. The sources point out that modern psychodynamic approaches have really evolved. They're generally much briefer. We're talking weeks or months, not usually years anymore.
And the style? Still the silent analyst?
No, much more interactive. The therapist talks more, engages more directly, and the focus has shifted too. Less emphasis on digging up distant childhood memories, especially around sexuality, and more focus on the client's current life, their present relationships, and how those unconscious patterns are playing out now. It's more practical, really, driven by research and just the realities of life and insurance.
Okay, that makes sense. So, moving from the deep past to the present, let's talk about humanistic therapy. This sounds like a completely different philosophy.
It really is a pivot. Humanistic theories focus on the subjective conscious experience. What's life like for you right now? And they emphasize everyone's unique potential for growth and self-development. It's much more optimistic, less deterministic than the psychodynamic view.
Carl Rogers and his client-centered therapy seem central here. Even the name client, not patient. feels different.
It signals a shift in power, definitely. Rogers believes the therapist isn't there to interpret or direct. Their job is to create a safe, nurturing space where the client can explore themselves.
How do they create that space?
Through 3 core conditions the therapist must provide. Empathy, really trying to see the world through the client's eyes. Unconditional positive regard, accepting the client totally, without judgment, no matter what they reveal. And genuineness, the therapist being real, authentic, not hiding behind a professional mask.
And if the therapist provides those 3 things?
The theory is the client feels safe enough to drop their own defenses, explore their true feelings, and start moving toward their potential. The therapist is more like a supportive guide than an expert telling them what's wrong. It's very non-directive. The client leads the way.
Okay, that sounds gentle, supportive. But then there's Gestalt therapy from Fritz Perls. Also humanistic, but the sources describe it as, well, not gentle.
Yeah, Gestalt is known for being much more active, more direct. It uses a lot of experiential exercises, especially role-playing. Things like the famous empty chair technique.
Where you talk to an empty chair.
As if someone important, maybe someone you have unfinished business with, is sitting there. The goal is to get feelings out into the open, make them conscious and immediate right now, integrate the fragmented parts of the self.
And the therapist's style reflects that immediacy.
Absolutely. It shifts dramatically from Rogers' non-directive approach. Gestalt therapists are often described as direct, even confrontational. They'll challenge clients constantly.
Oh, so?
They push clients to stop intellectualizing or talking about feelings and actually express them in the moment. If a client says, I felt angry yesterday, the therapist might cut in with, where is that anger in your body right now? Show me the anger now. It's about forcing present moment awareness.
Okay, 2 very different flavors within the humanistic umbrella.
Yeah.
Let's switch gears again to behavior therapy. This seems like a total departure from inner feelings and the unconscious.
Completely. Behavior therapy works on a simple premise. Psychological problems are basically learned behaviors. And if they're learned, they can be unlearned or replaced with more adaptive behaviors. It's all about observable actions and the principles of learning.
So no need to understand the why behind the behavior, just change the behavior itself.
Largely, yes. The focus is on the here and now, and on what's directly observable and measurable. This approach is particularly powerful for things like phobias, anxiety disorders, bad habits, anywhere the problem is clearly defined by behavior.
Let's talk techniques. For phobias, systematic desensitization is a classic. How does that work?
It's quite clever. It involves pairing exposure to the thing you fear with a state of deep relaxation. First step, you create a fear hierarchy.
A list of scary situations.
Exactly. Rank from least scary, maybe just thinking about a spider, to most scary, like holding one. Then the client learns deep relaxation techniques. Finally, you slowly work up the hierarchy, exposing the client to each step, often starting just in their imagination, while they maintain that relaxed state.
Why does that work?
Because deep relaxation and intense anxiety are physiologically incompatible. Your body can't really do both at the same time. So the relaxation response starts to overpower the fear response, gradually weakening that link between the stimulus, the spider, and the fear. You're essentially counter-conditioning the fear away.
Okay, training the body. How does that differ from gradual exposure?
Gradual exposure takes that principle into the real world. Instead of just imagining the spider, you're actually encountering it or situations related to it in gradual steps. Starting small, maybe looking at pictures, then being in the same room as a caged spider, eventually getting closer. It's direct real-life practice.
And technology plays a role now, too, with virtual reality therapy.
VR has been a game changer for exposure therapy. It lets therapists create incredibly realistic simulations of feared situations like flying, heights, public speaking, even combat scenarios for PTSD in a perfectly safe and controlled way. You can practice confronting the fear over and over without any real danger. The sources say it's very effective for things like fear of flying, acrophobia, heights, social phobia.
Makes sense. Behavior therapy also uses other learning principles, right? Like classical and operant conditioning.
Definitely. Aversive conditioning uses classical conditioning. You pair something associated with an undesirable behavior, like the taste of alcohol for someone with alcohol dependence, with something unpleasant, like a nausea-inducing drug. The goal is to create a negative, gut-level aversion to the problem behavior.
And operant conditioning. Rewards and punishments.
Yep, that's used to shape behavior too. Things like token economies, often used in schools or treatment centers. Positive behaviors earn tokens, points, whatever, which can then be exchanged for privileges or rewards. It's about reinforcing desired actions and weakening unwanted ones through consequences. Very systematic.
Okay, this focus on tangible change leads us nicely into the fourth major model, which seems to integrate some of these ideas, cognitive therapy, or often cognitive behavior therapy, CBT.
Right. CBT is probably the most widely practiced and researched approach today. It's really an integration. It takes the action-oriented techniques from behavior therapy, but adds a crucial layer, focusing on changing the faulty thinking patterns and negative beliefs that are seen as driving the problem behaviors and emotions.
So it's not just the situation, it's how you think about the situation.
Exactly. Two big names here. First, Albert Ellis and his Rational Emotive Behavior Therapy, REBT.
What was Ellis's main idea?
Ellis argued that emotional distress isn't caused directly by bad events, but by the irrational beliefs we hold about those events. Things like, I must be perfect at everything, or everyone must like me. When reality doesn't match these rigid demands, we get upset, anxious, depressed, angry. REBT directly attacks and disputes these irrational musts and shoulds.
Okay, challenging the core beliefs.
Yeah.
How does that compare to Aaron Beck's cognitive therapy, CT?
Beck focused more on identifying specific distorted patterns of thinking. Things like,
What kind of pattern?
like catastrophizing, blowing things way out of proportion. I failed the test, my life is over. Or overgeneralization, taking one negative event as proof of a never-ending pattern. I got rejected for that date, I'll always be alone. Or personalization, blaming yourself for things you're not responsible for.
And what does the therapy do about those patterns?
CT helps clients first recognize these automatic negative thoughts and cognitive distortions. Then they learn to challenge them and replace them with more realistic, balanced thoughts. Beck often used homework assignments, like keeping a thought diary to track the distorted thoughts and practice substituting more rational alternatives.
So both Ellis and Beck are about changing thinking, but the sources mention a difference in style.
Yeah, that's a key distinction. REBT therapists following Ellis tend to be very direct, sometimes even quite confrontational. They'll actively argue against the client's irrational beliefs. That's an absurd way to think. Why must you be perfect?
Whereas Beck's approach.
Beck's CT is generally described as gentler, more collaborative. The therapist acts more like a guide, helping the client discover the distortions and challenge them themselves, often using Socratic questioning, asking questions to lead the client to their own insights. It feels less like a debate, more like teamwork. Both aim for rational thinking, just different ways of getting there.
Okay, we've got these four big theoretical pillars. But in the real world, therapists aren't always purists, are they? This brings up eclectic therapy.
Right. Most therapists today probably identify as eclectic or integrative. It's really about pragmatism. They don't stick rigidly to just one school of thought.
They mix and match.
Exactly. They draw on techniques and principles from different models depending on the client and the specific problem they're facing. Maybe use some behavioral techniques like exposure for immediate anxiety relief, but also explore deeper relationship patterns using psychodynamic ideas. It's about using the best tool for the job at hand, rather than forcing every problem into one theoretical box.
Makes sense. Now, therapy isn't always one-on-one. Group therapy is really common, too. What are the pros and cons there?
Group therapy has some big advantages. First off, it's usually less expensive, which makes therapy accessible to more people.
And clinically?
Clinically, it can be incredibly helpful, especially for issues like loneliness, shyness, social anxiety, or low self-esteem. Just being in a room with others facing similar struggles can be very validating and reduce feelings of isolation.
And you can learn from others.
That's a huge benefit. Clients get to see how others cope, hear different perspectives, practice social skills in a safe environment, and get feedback. It's powerful modeling and mutual support.
But the sources say it's not for everyone.
No, definitely not. Some people are just too inhibited or anxious to feel comfortable sharing personal stuff in a group. Others might need more individual attention than a group setting can provide. And for some conditions, like severe paranoia perhaps, it might not be appropriate.
And then there are therapies focused specifically on relationships, family, and couple therapy.
Right. Here, the client isn't just one person, it's the relationship system itself. In family therapy, the focus shifts from seeing one person as the problem, like a rebellious teen, to understanding the patterns of communication, roles, and conflicts within the whole family unit. How does the system function, and how can it be healthier?
And couple therapy? Similar idea.
Similar idea, but focused obviously on the dyad. Helping distressed couples improve communication, resolve conflicts more constructively, understand each other's needs better. It's about repairing and strengthening the relationship itself.
Okay, so we have all these different approaches, different formats, which leads to the million-dollar question. Does any of this actually work? How do we measure success?
That's the critical question, and researchers use a powerful tool called meta-analysis to answer it. They statistically combine the results from many individual studies comparing therapy to no treatment or different therapies to each other.
And what's the verdict from these meta-analyses?
The overall verdict is pretty clear. Psychotherapy works. People who get therapy generally do significantly better than those who don't.
Are there numbers on that? Like, how much better?
The sources mention figures like around 50% of clients showing significant improvement within about 21 sessions. That's a substantial effect.
Yeah.
But it's important to add a caveat.
Which is?
It doesn't work for everyone. Sadly, a small percentage of people might actually get worse during therapy, though that's rare. And improvement doesn't always mean a complete cure.
Okay, so therapy is generally effective. But what about comparing the different types? Is one model better than the others? We hear about the dodo bird verdict.
Ah, yes, the dodo bird verdict from Alice in Wonderland. Everybody has won and all must have prizes. For a long time, meta-analyses suggested that most major forms of therapy produced roughly similar levels of overall improvement when compared head-to-head.
Why would that be, if the theories are so different?
It points to the importance of non-specific factors, sometimes called common factors. These are elements present in almost all effective therapy, regardless of the specific model.
Like what?
Things like having a supportive therapeutic relationship, feeling understood, gaining hope, expectation for change, getting attention from a caring professional, having a plausible explanation for your problems. These common factors seem to account for a lot of the positive outcomes.
The sources also suggest maybe it's not quite at bed heat, that CBT might have a bit of an edge.
That's right. While the common factors are huge, more recent and refined analyses, especially for specific disorders, do tend to show CBT holding a slight overall advantage in effectiveness.
Why might that be?
Possibly because CBT focuses on specific skills and measurable changes in thoughts and behaviors. This makes its effects easier to quantify in research studies, especially for very specific problems like panic attacks or OCD, where you can clearly measure symptom reduction.
But that doesn't mean the other models aren't valuable, right? Like modern psychodynamic therapy.
Absolutely not. The sources are clear that contemporary psychodynamic approaches show good evidence for effectiveness, particularly for problems rooted in personality patterns and relationship difficulties. Think depression, borderline personality disorder, certain anxiety disorders, eating disorders like bulimia.
And humanistic therapies.
While maybe harder to measure in traditional symptom reduction studies, humanistic approaches are seen as very valuable for helping people with personal growth, finding meaning, improving self-esteem, and developing a more cohesive sense of self. Different tools for different goals.
This focus on proof has led to the push for evidence-based treatment, hasn't it?
Yes, hugely important. It means therapists in healthcare systems are increasingly expected to use treatments that have solid research backing, demonstrating they actually work for specific conditions. It combines those specific factors, unique techniques of a model like exposure and CBT, with the crucial non-specific factors like the therapeutic alliance. Good therapy uses both.
One last crucial point in this section: multicultural issues. Therapy doesn't happen in a vacuum.
It absolutely doesn't. Therapists must be culturally sensitive. That means understanding and respecting the client's cultural background, ethnicity, values, beliefs. It's not just about being aware of differences. It's about potentially adapting the treatment approach so it makes sense and resonates within the client's cultural context.
And therapists need to be aware of their own biases, too.
Critically important. Therapists need to examine their own cultural assumptions and potential biases to avoid stereotyping clients or misinterpreting behaviors through their own cultural lens. Effective therapy requires genuine cultural humility.
Okay, we've covered the psychological approaches, the talking cures. Now let's shift gears entirely to the biomedical therapies. These interventions target the body, primarily the brain, often using medication.
Right. This approach views mental disorders as having biological underpinnings that can be treated with medical methods. The most common are psychotropic drugs, which work by altering neurotransmitter systems in the brain to help regulate mood, thinking, and behavior.
Let's break down the main categories our sources mention. First up, anti-anxiety drugs. Things like Valium or Xanax.
These are used to relieve anxiety, tension, nervousness, pretty quickly. They primarily act on a neurotransmitter called GABA.
GABA, what does that do?
GABA is the brain's main inhibitory neurotransmitter. It basically tells neurons to slow down to stop firing. These anti-anxiety drugs, often called benzodiazepines, make GABA receptors more sensitive. So they enhance GABA's calming effect, quieting down the nervous system.
But there's a downside.
A big one. The sources warn they can be highly addictive, both physically and psychologically. So they're generally recommended only for short-term use or very carefully managed situations. Dependence is a serious risk.
Okay, then the huge category, antidepressants. How do they work?
The main goal of most antidepressants is to increase the levels of certain neurotransmitters in the synapse, the gap between nerve cells, particularly norepinephrine and serotonin, which are heavily involved in regulating mood. Low levels are linked to depression.
And there are different types, different generations.
Yes. The older classes include the tricyclics. They work by blocking the reuptake of both norepinephrine and serotonin.
Reuptake, meaning?
After a neurotransmitter sends its signal, it normally gets vacuumed back up by the sending neuron to be reused or broken down. Reuptake inhibitors block that vacuuming process, leaving more of the neurotransmitter hanging around in the synapse to keep stimulating the next neuron.
Okay, then there were the MAO inhibitors.
Right. Monoamine oxidase, MAO, is an enzyme that naturally breaks down norepinephrine and serotonin in the synapse. MAO inhibitors block that enzyme, so the neurotransmitters stick around longer because they're not getting cleaned up as quickly.
But these older drugs had side effects, didn't they?
They did, and MAOIs in particular required strict dietary restrictions because they could interact dangerously with certain foods. That's why the newer generation became dominant, the SSRIs.
Selective serotonin reuptake inhibitors, like Prozac, Zoloft.
Exactly. As the name suggests, they are much more selective. They primarily block the reuptake pump just for serotonin. By leaving more serotonin available in the synapse, they help normalize mood circuits, but generally with fewer side effects than the older, broader-acting drugs. They became the first-line treatment for depression for many years.
Got it. Now, for more severe disorders involving psychosis, hallucinations, delusions, we have antipsychotics.
Yes, these are crucial for managing conditions like schizophrenia. They primarily work by blocking receptors for the neurotransmitter dopamine. Too much dopamine activity in certain brain pathways is linked to psychotic symptoms.
Are there different kinds here too?
Definitely. The first generation drugs like thorazine, phenothiazines, were effective at reducing hallucinations and delusions, but they often cause really unpleasant, sometimes permanent side effects involving muscle control and movement, kind of Parkinson's-like symptoms.
So newer ones were developed.
Yes, the atypical antipsychotics like clozapine or risperidone, they still affect dopamine, but often serotonin too, and they tend to have a lower risk of those severe neurological side effects. The sources suggest they might also be better at treating the negative symptoms of schizophrenia, like withdrawal and apathy, and might lead to lower relapse rates. Still significant side effects possible, but often a better profile.
We should also briefly mention other specific drug types, like mood stabilizers.
Right, like lithium. That's the classic treatment for bipolar disorder. It helps prevent the extreme mood swings, both the mania and the depression. How it works isn't fully understood, but it's very effective for many.
And stimulants for ADHD.
Yeah, drugs like Ritalin or Adderall. It seems counterintuitive to give stimulants to someone who's hyperactive, but they actually help activate the parts of the brain responsible for attention and impulse control, leading to improved focus and calmer behavior in people with ADHD.
Okay, so these drugs have been revolutionary in many ways, but the sources emphasize they're not a magic bullet, especially regarding relapse.
This is such a critical point, connecting back to the talk therapies. Drugs can be incredibly helpful, life-saving even, but they often only manage symptoms while you're taking them.
So what happens when you stop?
Relapse is very common, and the sources suggest a key reason why. Patients who only receive medication haven't necessarily learned the underlying skills to cope with stress, manage difficult emotions, challenge negative thinking patterns, or solve interpersonal problems. They've treated the brain chemistry, perhaps, but not the behavioral or cognitive habits that contribute to the disorder.
So the problem often comes back because the person hasn't learned new ways to handle it.
Exactly. This really highlights the potential benefit, for many conditions, of combining medication for stabilization with psychotherapy for skills and insight. The skills learned in therapy can provide more lasting resilience.
Beyond medication, there are more direct physical interventions. Let's talk about electroconvulsive therapy, ECT. This sounds quite dramatic.
It is. ECT involves passing a controlled electric current through the brain to induce a brief seizure. It sounds scary, and historically it was sometimes used inappropriately. But today, it's done under anesthesia with muscle relaxants.
And who is it used for?
It's reserved almost exclusively for cases of severe treatment-resistant depression, especially when there's a high risk of suicide or the person isn't responding to medication or therapy at all. For those specific cases, ECT can actually be remarkably effective, sometimes producing dramatic improvement very quickly when nothing else has worked.
But we don't fully understand how it works.
That's the fascinating part. The exact mechanism is still unclear. The leading theories involve the seizure causing widespread changes in neurotransmitter levels, or perhaps affecting the connectivity in brain circuits involved in mood regulation. But it's still a bit of a mystery.
And there are downsides.
Yes. The main ones are potential short-term memory loss around the time of the treatments, although techniques have improved to minimize this. And like with drugs, there's a relatively high rate of relapse if it's not followed up with other treatments like medication or therapy.
Okay, and then the most extreme intervention, psychosurgery, brain surgery for behavior control.
Yeah, this is truly a treatment of last resort, and its history is troubled. We have to mention the prefrontal lobotomy.
That sounds ominous.
It was. Developed in the 1930s, it involved surgically severing connections between the prefrontal cortex and lower brain areas. It was used widely for a time, but often had devastating consequences. Profound personality changes, loss of initiative, intellectual impairment. Thankfully, it's basically non-existent now, largely replaced by effective medications.
So modern psychosurgery is different.
Vastly different. It's extremely rare, highly targeted, and uses much more precise techniques to lesion very small, specific brain areas implicated in severe intractable disorders like OCD when absolutely everything else has failed.
And there are even less invasive surgical approaches being explored.
Yes, things like deep brain stimulation, DBS. This involves implanting electrodes in specific brain regions connected to a device like a pacemaker. It delivers continuous, low-level electrical stimulation. It's being investigated and sometimes used for severe depression, OCD, and other conditions. The idea is to modulate and normalize activity in faulty brain circuits without destroying tissue. Related techniques using magnetic stimulation are also being explored, still largely experimental for mental health, but promising.
So we've seen the evolution of treatments, both psychological and biomedical. But where treatment happens has also undergone a massive shift. Let's talk about the community mental health movement.
This was a huge policy change starting around the 1960s. The goal was to move away from warehousing people with serious mental illness in large, isolated state psychiatric hospitals, often for life, and provide care within their own communities instead.
The idea being reintegration, better quality of life.
Exactly. The hope was to provide more humane, less restrictive care and help people function within society. The main policy driving this was deinstitutionalization. States began closing down those huge hospitals and discharging patients, theoretically, into community-based care.
And what were these community mental health centers supposed to offer?
They were envisioned as comprehensive service hubs, offering outpatient therapy, medication management, day programs providing structure and support, crisis intervention services, basically a local one-stop shop for mental health needs.
A good idea in theory. But the sources suggest the reality has been challenging.
That's putting it mildly. The success has been very mixed. While the goal of closing large institutions was largely achieved, the promised community infrastructure often failed to materialize adequately.
Meaning?
Too many patients, especially those with the most severe and persistent mental illnesses like schizophrenia, didn't get the comprehensive, continuous support they needed after discharge. The community centers were, and often still are, chronically underfunded and understaffed. They struggle to meet the immense demand.
And we see the results of that gap.
Sadly, yes. While most people with severe mental illness now live in the community, the sources estimate that maybe only about half actually receive consistent treatment. This lack of adequate support is a major factor contributing to homelessness, substance abuse, frequent crises, and the revolving door phenomenon, where people cycle in and out of emergency rooms and short-term hospital stays, and unfortunately, the justice system.
So just having a center nearby isn't enough, especially for complex cases.
It seems not. The evidence points towards the need for more intensive, proactive, community-based programs. Things like assertive community treatment, ACT teams.
What do they do differently?
Instead of waiting for clients to come in, these teams go out to the clients. They provide comprehensive, wraparound services, medication monitoring, therapy, help with housing, employment, daily living skills delivered directly in the community by a dedicated team. They actively engage clients and match services very specifically to their needs. These more intensive models show much better results for people with severe mental illness. But again, they require adequate funding and staffing. Hashtag tag outro.
Wow. Okay, we've covered a huge amount of ground today, from Freud's couch and unconscious conflicts, through Rogers' empathy, Skinner's learned behaviors, Beck's cognitive distortions, all the way to SSRIs, ECT, and the complex realities of community care.
It's a lot. We've seen that psychotherapy in its various forms demonstrably works for many people. Meta-analyses back that up, with CBT often showing a slight edge in measurable outcomes, perhaps due to its focus on skills and concrete changes. But those non-specific factors the relationship hope are incredibly powerful too.
And on the biomedical side, psychotropic drugs have transformed treatment, especially for severe disorders, offering vital stabilization. But we also heard that critical warning about relapse when medication is the only intervention, because it doesn't teach coping skills.
Right, which really underscores what the sources suggest. For many, maybe most, lasting recovery and stability might best be achieved through an integrated approach, combining the biological stabilization from medication, when needed, with the skills, insight, and resilience built through psychological therapy.
Which brings us to a final thought, linking the treatments to the system itself. Given the often underfunded state of community mental health and that problem of relapse with medication-only approaches, how crucial is it that our mental health care system really prioritizes integrating these approaches, making sure skill-building therapies are just as accessible and emphasized as the biomedical options?
Is that integration, that focus on learned skills alongside symptom management, the missing piece needed to ensure more lasting stability for people navigating mental health challenges? What do you, our listeners, think is the most critical element we need to strengthen in our current system based on everything we've explored today?
Something important to reflect on. That's all the time we have for this deep dive. Thanks for joining us.
See you next time.